And we're back. We have Ilana Ackerman from Australia. This is a big day and weekend for you, Ilana, or for all the Australians, I guess. One, can you tell people who you are and what you do? And then why is this weekend so big for you guys?
Hi, Chris. Great to be here with you. Thanks for having me. So my name's Alana Ackerman. I'm a professor in the School of Public Health and Preventive Medicine at Monash University in Australia. I am a musculoskeletal epidemiologist, so I lead research into the burden and impacts of osteoarthritis and other musculoskeletal conditions, and also in the use and outcomes of joint replacement surgery. I'm also a physiotherapist by background, so I worked clinically as a physiotherapist for over 20 years in acute settings, acute hospital settings and rehabilitation settings, working mostly with people before and after joint replacement surgery, and also helping people recover from fractures and other types of orthopedic surgery. And it's a really big weekend in Melbourne at the moment because it's a grand final day today. So we have the AFL, Australian Football League, grand final in Melbourne today, and we had the parade and public holiday yesterday, and then the big matches this afternoon.
Yeah, so for this call and for this conversation, it's directed towards a recent publication from Australia, and you all create these clinical care standards, which I've been extremely impressed with. I read the low back one, which I think came out a year or two prior, and this clinical care standard for knee osteoarthritis, I think came out in 2024 this year, and you're one of the authors. So can you tell the audience what a clinical care standard is, and then what your role and involvement was within this specific knee osteoarthritis piece?
Sure. Well, the Australian Commission on Safety and Quality in Healthcare has released a range of clinical care standards across different clinical conditions and different treatment procedures. And one of those is on osteoarthritis of the knee, as you've mentioned. And so those clinical care standards, they're really designed to support evidence-based care and reduce variation in clinical care, and also to help promote shared decision-making between patients and health professionals. And unlike clinical care guidelines, they don't cover all the different types of treatment that might be provided, but instead they provide a limited set of quality statements that are designed to cover the full spectrum of best practice care. So the expected care that someone with a particular condition or undergoing a particular procedure might be expected to receive. And so my role for the osteoarthritis of the knee clinical care standard that was originally launched back in 2017 based on evidence of low value care at that time, so really high rates of knee arthroscopy among older Australians, which is an example of low value care because there's little to no benefit for patients and carries risk of harms as well. So the first clinical care standard for osteoarthritis of the knee was developed and released then. And in 2024, that has been reviewed and updated based on emerging evidence and newer clinical guidelines from around the world, and also to address some of the broader and newer priorities for improving quality of care. And so for that review process, the Commission convened an expert working group across a range of clinical expertise, so from general practice and rheumatology, physiotherapy, orthopedic surgery, radiology, pharmacy, dietetics, and also consumer representation. And I was one of two physiotherapists who were on that working group, and I was also on the original working group that developed the first clinical care standard back in 2017.
The plan today is to dive into the clinical care standard and those 8 quality statements. But before we do that, can you just define and dive into as much as you feel is appropriate what osteoarthritis of the knee actually is and means?
Sure, good question. Good way to start off. So knee osteoarthritis is a chronic condition affecting the knee, mainly the tibiofemoral joint, but it can certainly also affect the patellofemoral joint. We always used to think of knee osteoarthritis as a degenerative condition, but more recently we know now that there's also an inflammatory component as well. Importantly, to understand it's not just the articular cartilage that's involved in knee osteoarthritis, but really we can think about it as a whole of joint conditions. So yes, the cartilage is affected, but also the bones can be affected, the ligaments, the meniscus, the muscles around the joint. And, the most common sort of symptoms, of course, pain and stiffness and impaired function, but it can have a broad range of effects on quality of life and work participation, etc. I guess it's also important to clear up some misconceptions about knee osteoarthritis. So can be a range of severities, so ranging from mild symptoms through to more severe symptoms. Not everybody will progress to more severe symptoms or more severe knee osteoarthritis. And importantly, not everybody will need joint replacement surgery. So I think that's one of the things that people often think, that if you have knee osteoarthritis, it's inevitable that you will need joint replacement surgery at one stage. And that's not the case. Really, only a very small proportion of people will go on to need joint replacement, and the remainder can manage and live really well with effective non-surgical management.
Is knee OA the most common form of OA?
It is, yeah. So in Australia, we say that about 2.1 million people have osteoarthritis, and of them, about 60% will have knee osteoarthritis. It is very common.
There's 8 quality statements for this clinical care standard. I want to dive into each one. Are you able to just list the 8, and then we can kind of go sequentially down into each?
Yeah, sure. So the first one is around comprehensive assessment and diagnosis, then appropriate use of imaging, then education and self-management, physical activity and exercise, weight management and nutrition, medicines that are used to manage pain and mobility, patient review, and then surgery.
Before we dive into the first one, when these working groups came together, was there already an idea of how many quality statements or what was the range y'all were looking for? How hard or easy was it to come up with these 8 statements?
I don't remember that there was a particular number that we had in mind, but certainly thinking back to the original topic working group, there was certainly the key elements of care that everybody wanted to address. And remember, this was a really broad multidisciplinary group, so everybody came to the group with their own experiences of working with people who had knee osteoarthritis. But we certainly wanted to cover that full spectrum of care. There were things that we felt were really important to consider. So that review statement, for example, that we'll talk about today, and they link, the statements link back well with these priorities for high value care and for reducing low value care. For example, the statements around imaging and medicines, and we'll talk through those today as well.
Let's go into the quality statement number 1, comprehensive assessment and diagnosis. Yeah. What are these major recommendations within that statement?
So this first statement is about making a really, holistic, person-centered assessment. And that's something that I think we do well as physiotherapists anyway. But it's really about having the confidence to make that diagnosis of knee osteoarthritis based on that comprehensive clinical assessment without the use of imaging. So someone who is suspected of or who has knee osteoarthritis and is coming for their initial assessment, it's really important to take a detailed history of their symptoms and their medical history, any comorbidities they may have. Obviously, a physical and a functional assessment. So assessing the knee in terms of palpation and strength and range of movement, but also gait assessment, other functional activities as appropriate. It may also be appropriate to administer some patient-reported outcome measures, for example, capturing pain using a visual analog scale or similar, a measure of function and perhaps a measure of quality of life. But in this assessment, it's really important to understand have a psychosocial evaluation as well. So of someone's mental health and emotional well-being, their life in terms of their work roles and their social roles and community roles, because all of that can impact someone's treatment program and the goal setting as well.
And within each of these statements, y'all did a great job providing these examples of communicating these things to patients. Yeah. Within this first comprehensive assessment and diagnosis, can you touch on what that may look like with this communication?
Sure. So the communication tips that have been provided as part of this clinical care standard are great. I agree. They're really practical sort of advice and suggestions that clinicians can use with patients. So this first one is around helping people understand what knee osteoarthritis is through really positively framed language. And at the outset, it's really important for us as clinicians to avoid using terms that can be potentially harmful and lead to unhelpful beliefs. So we really want to avoid using those kind of outdated negative terms such as wear and tear and bone on bone that are really structurally focused and joint centric, and they're not part of that holistic sort of approach to thinking about knee osteoarthritis. So right at the outset, we want people to understand that, we are doing this very comprehensive assessment to understand what's going on with their knee, but also what's going on with them, more holistically as a person, and how those varying different factors will help us understand their experience with knee osteoarthritis.
So you mentioned some maybe unhelpful language or old, outdated terms. When a patient maybe, questions if you push back or you try to provide other alternative explanations, but they said, my physician told me it's bone on bone or it's degenerative. How do we balance not, disagreeing with another healthcare provider, but providing a little bit more nuance to reframe it to the patient? Do you have any recommendations?
So I think we can talk about in terms of, we now know, for example, that, knees are strong and they stay healthy through movement, and exercise helps us to not only keep our knees strong, but for our overall health and well-being, and really positively framed messaging around staying active, staying healthy, using our knees, getting back to the activities that we enjoy. So much more, it's not to say that we need to necessarily contradict what another health professional is saying, but we can provide some more positively framed language to help patients engage with, the things that we want to do, because the terms that we're talking about, those negative kind of terms, they can make people really fearful about causing, for example, damage to their knee, or they might see exercise as a risky activity. If they think that they've got, bone, or they've heard bone on bone, they might think that it's potentially harmful to be engaging in physical activity and exercise. So we do need to clear up some of those misconceptions about what knee osteoarthritis is, and what we now know from the evidence, that what we can do to help people live well with their condition.
To staying on the assessment piece as a clinician, is there anything that would necessarily guide us in a direction kind of objectively that we're looking for, or is so much of the knee OA diagnosis based off of their subjective reports? And is there any, objective testing that should be performed or that rules out other items, or is it mainly what they're telling and their kind of demographics, their age and their history that gives the most information?
Yeah, so we're mostly, aligned, let's say, with the NICE guidelines in the UK, which is talks about, so for people aged 45 years and over who have activity-related joint pain and have either no morning stiffness or morning stiffness that lasts for less than 30 minutes. If we have those things in mind, plus the clinical picture that someone's telling us in terms of, difficulty with certain activities, going up and down stairs, up and down from a chair, etc., in and out of a car, so knee-related functional sort of impairments. Plus, we've got in mind their age group and the fact that the pain is related to various activities, and also the short-term stiffness that they're having. That would all point us in the direction of making this clinical diagnosis of knee osteoarthritis in that age group.
Let's go to number 2, the quality statement of appropriate use of imaging. What are the recommendations here?
Yeah, so this is an important one because obviously over-imaging is a problem, and it can lead patients down a path of unnecessary treatment and unwarranted surgery if things are, for example, picked up on imaging such as x-rays. So this statement is really clear that imaging is not routinely used to diagnose knee osteoarthritis, and coming back to our comprehensive assessment that can be made on a clinical, we can make a clinical diagnosis. This one is around discussing really the limited value of imaging with patients. So, we can be talking to patients about that imaging or x-rays, if we use the example, are not needed to make the initial diagnosis of knee osteoarthritis. It's not needed to guide the treatment. And in fact, your treatment plan will be guided by, your pain, your mobility, and your function. We don't need the x-rays to do that. And I think this can be used to bring up a broader conversation with patients that there's a really poor link between what might be seen on x-ray and what they might be experiencing. So, if we have two x-rays that show the same sort of structural changes, but people might experience that very differently in terms of their symptoms. And we can have one person who has quite marked changes on x-ray, for example, but could have quite mild symptoms, and then vice versa. So the imaging really doesn't correlate with what we see clinically, and we don't need it in the first instance to diagnose knee osteoarthritis. In situations where someone has symptoms that are possibly unusual for knee osteoarthritis, or there may be some atypical features, so perhaps a red, hot, swollen joint or rapidly deteriorating symptoms, then we might be starting to think about other diagnoses, and perhaps imaging in those very limited circumstances might be needed to rule out those other potential diagnoses. But for uncomplicated knee osteoarthritis, the imaging is not needed.
And you pretty much already touched on that communication piece and those high base rates of the prevalence of the findings and how they aren't well correlated between the pain and the function and the severity of the findings. Let's go to number 3. Let's keep chipping away. Education and self-management. What are the recommendations here?
So education, self-management, this is one of the mainstays of non-surgical management for knee osteoarthritis. So it's really about empowering our patients through providing information that helps them understand what knee osteoarthritis is, what the likely sort of prognosis might be, and what the available treatment options are. It's about helping people to understand all of that information in a way that's accessible and easy for them to kind of follow and to align with their preferences. So do they want to have information that's provided in a written format? Do they want to access online information? It's also a time perhaps to give patients the links to some online education programs if that's what they may be interested in. The self-management aspect of this quality statement is also really important. So it's about working with the patient to develop an individualized, tailored plan, self-management plan that addresses their health needs and their goals in their own situation as well.
And communication aspect, is there anything you want to touch on there, or where can these resources, if we want to provide resources to patients more on this piece for them to kind of refer back to, where can they find those items?
Yeah, so there are a lot of good, evidence-based resources online, and the clinical care standard document certainly does provide links to those. And also, I should add that the care standard does come along with fact sheets and consumer resources that are all online. There are specific online education programs for arthritis around the world. There are also plenty of information available from arthritis foundations, etc., that patients can easily access. In terms of communicating with patients through around this quality statement, again, it's using that kind of language that will support people to manage their knee osteoarthritis proactively, and really using that positively framed language around being healthy and strong and maintaining a healthy joint and getting back to doing the activities that they're wanting to do.
Physical activity and exercise, what can we recommend there?
So physical activity and exercise is, again, one of the mainstays of non-surgical management. It's something that we also focus on, obviously, as physiotherapists. So importantly, this one covers both physical activity and exercise. So exercise in terms of a tailored exercise program to improve knee strength and endurance and specific impairments that we've identified through our assessment. That's obviously also very important, but so is the physical activity in terms of maintaining, general health and well-being. And physical activity might be, incidental exercise, it might be leisure activities, it might be sporting activities. So I think what's important with this quality of statement as well is that the advice that's given around physical activity and exercise is in line with the patient's own, preferences and goals and activities that they will find enjoyable. As part of this quality statement, it's important to work with the patient to help them develop some goals, some realistic and achievable goals around physical activity and exercise, and also, again, to link them in with any services or programs that might be needed to help people achieve those goals.
There's a lot of unhelpful and harmful beliefs around certain types of exercise. Yeah. With worsening of knee OA or things to completely avoid. Can we dive into some of those, and maybe starting with running? A lot of individuals think that running is wearing someone's joints down, making their knee OA worse. Is there a correlation between running or more running volumes and worsening knee OA? What can you talk about with running?
So that's a good question. There's been lots of articles and studies published about this. So no, running is not going to make your knee osteoarthritis worse, and it is certainly safe to run, especially if that's something that you enjoy doing and you've always been doing it. It's certainly safe to keep doing that. There's certainly ways that you can make running more comfortable. If that's something you're wanting to keep doing, and I highly recommend that if that's something people are interested in, that they do speak with their physiotherapist or their health professional about ways to do that, because there may be some retraining of their technique that might be needed, or for example some advice around their footwear or running on softer surfaces, for example, that may make them more comfortable to do that. I think it's hard in some of those sort of epidemiology studies around running to kind of tease out what's going on there in terms of training load and injuries that might be sustained. So it's kind of hard to establish exactly those kind of causal mechanisms. But in general terms, running is safe and safe for people to continue if that's something that they enjoy doing. But they should definitely work with their physiotherapist in terms of making sure that they're sort of best set up to do their running program.
Is there any type of exercise or exercise program that is inherently more beneficial to perform or recommended over other forms of exercise for a knee OA?
It really comes down to context and goals and preferences. I mean, the old adage that the best exercise for you is the exercise that you will do. And in terms of committing and staying with an exercise program, it's really important for people to find something that they enjoy doing and that they can easily access. So, for example, there's little point in prescribing or recommending that someone goes to the gym and do a gym-based program if that's not something they want to be doing, or they don't have a local gym, or the cost is prohibitive for them. It would be much better to design them, for example, a home exercise program that they could do with equipment, or an online or telehealth program that they could do more easily. So any exercise will be beneficial, whether that's land-based, water-based exercise, something that you enjoy. I think with the guidance of your physiotherapist, you can certainly have an exercise program that is tailored for you and for your needs and for the impairments that were identified as part of the assessment. And then really importantly, that program needs to be reviewed over time and progressed as needed or modified as needed, depending on symptoms. And as your strength and endurance improves, it needs to be progressed accordingly as well.
And if a patient were to ask, well, why is this recommended? Obviously, it's beneficial to be healthy and remain active, but what should we utilize as the narrative, or are there more helpful strategies for trying to explain what is exercise actually doing, and do we know what it's doing from a knee OA perspective?
Well, I think we can explain it in terms that it really has a multitude of benefits. So not only does exercise benefit the knee through improving strength and increasing range of movement and helping us return to functional activities, but exercise has a benefit for overall health. So in terms of improving our cardiovascular health and ability to do our activities of daily living and all the things we want to do. I think it's also, important to have conversations with people that the exercise that you do for your knee osteoarthritis and the physical activity that you do will be beneficial for any other health conditions that you have. So remember that people living with knee osteoarthritis may also commonly have cardiovascular conditions. They may have diabetes, other conditions. So the exercise will have sort of flow-on benefits for those other health conditions as well, and can also have benefits for weight management, which we'll talk about next as well.
And if someone asks how much pain is appropriate for me when I'm exercising, or can I exercise with some level of knee discomfort, are there any kind of guidelines or buffers or parameters there?
Yeah, there's not sort of firm guidelines as such, but it is very normal to have some pain while exercising. So the sorts of advice we'll be saying is that's perfectly normal. It's safe to continue with exercise. We would want you to monitor your pain once you stop exercising, and we would expect that pain to settle within a couple of hours or so, or by the next day. But to let us know and come back to us if you're finding that the pain persists after that exercise. Come back. We'll review the exercises that you're doing. We may modify the starting position or the repetitions or the load, and design the program so it's most comfortable for you to do. I think we should definitely be reassuring patients that they are not causing any harm while they're doing the exercise, including if they're feeling some pain. And then we also talk about, as we'll come to one of the next quality statements, is that those medicines that are used to manage pain and mobility, and having them as if needed, as an adjunctive sort of measure so that people can exercise more comfortably. But it might be also around finding a type of exercise that's most comfortable. So perhaps that's a chair-based exercise initially rather than a standing weight-bearing exercise, or perhaps it's a water-based exercise that might be more comfortable.
Weight management and nutrition is the next area. What, again, are the recommendations for clinicians?
So this quality statement is really about supporting patients to maintain a healthy and sustainable weight, largely through exercise, physical activity, and optimal nutrition. So this is obviously quite a sensitive area to bring up with patients. It's really important for us to be empathetic and non-judgmental, and to acknowledge with patients that, losing weight, if that's what needed, is challenging, and to acknowledge what they might have already tried so far in doing that. But this statement is about weight management, not just weight loss. It's also about preventing weight gain and maintaining that healthy weight. And, to achieve this weight management, we might need to also recommend that the patient works with their general practitioner, primary care physician, and also with an accredited dietitian, perhaps, to help them achieve this. And this one comes down to some conversations around perhaps losing a small amount of weight might help you with your knee symptoms and your mobility and your overall health. Is that something you might like to talk about or to work on or to speak with another health professional about? And even conversations about losing a relatively small amount of weight. So perhaps 5 to 10% of body weight might help somebody in terms of improvement in their pain and improvement in their mobility and function as well.
If someone were to ask if I'm recommended to lose some amount of weight, but you're also recommend me to load my knee and resistance train and put force through it, how does that make sense if I should be placing less load through losing weight, but also loading the structures of the knee? How do we interact with that conversation?
Yeah, that is a good question, Chris. So I think that comes back to this kind of this traditional paradigm of damage to the knee, and why we want to be moving away from that. Because when we talk about this bone on bone and wear and tear, that people do have in their minds that there is structural damage to the knee, and that putting extra load through the knee will be harmful or could cause further harm, and we need to be moving away from that language. So this comes back to us talking about that knees are designed, the knee joint is strong and it's designed to be loaded, and we really want to keep the muscles around the knee very strong so that we can do all the activities or get back to the activities we want to be doing. In terms of weight loss, I guess this links into what we know now about the inflammatory part of knee osteoarthritis as well. So, we do know that fat tissue, adipose tissue, does release these kind of pro-inflammatory mediators that can set up inflammation around the knee joint. So it's not just the weight going through the knee here, but we've also got the inflammatory component. But there's a difference between loading a joint to promote joint health and trying to lose weight for overall health and knee health as well. So we really do want to talk about keeping those knee joints strong and that they are designed to be used in that way.
And the next one is medicines used to manage pain and mobility.
So this one is also, I guess, addressing one of the aspects of low value care, which is the overuse of opioids. And in this statement, there's a very clear statement that opioid analgesics should not be used for knee osteoarthritis because the risk of harms are very real and they outweigh the benefits. We really have no evidence to show any benefit for the use of opioids for chronic non-cancer pain, such as knee osteoarthritis. And obviously the side effects and harms that go with that. So in this statement, it's really outlining that medicines are an adjunct to everything else that we're doing. They're not to replace exercise. They're not to replace self-management strategies. They are used to allow people to engage in those self-management strategies and to maintain or improve their physical activity and their exercise. Part of this one, physiotherapists in most settings are not involved in the medication side of things directly, but it's also a time to perhaps have a conversation and recommend that the patient have a chat with their general practitioner or their pharmacist to talk about the medications that they're using. And really we would talk to people about these are used alongside everything else that we're doing and not as a replacement for the exercise and self-management activities.
And does that also go for corticosteroid injections or any type of injections? Are there other more specific recommendations there?
Yeah. So there also is a recommendation to not have platelet-rich plasma injections and stem cell injections, given, again, the lack of evidence of those interventions for knee osteoarthritis and the potential risk of harms. In terms of corticosteroid injections, that's probably something we would recommend in the first instance that someone speak to the general practitioner about, and whether or not they decide to refer them on to a rheumatologist or a sport and exercise physician for consideration of those injections, corticosteroid injections in their circumstances. But there's certainly a strong statement against platelet-rich plasma and stem cells.
Patient review. What are the recommendations and what does that mean?
So patient review, and this I guess comes back to the goals that were set earlier and, following on from that comprehensive assessment. So it's important to have a review process and a time frame that's agreed with, the patient and the clinician agree on that together. So it might be that you both agree that we're going to have a review in 3 months' time or each 3 months to see how you're going. And that's an opportunity to repeat that comprehensive assessment and, re-administer those patient-reported outcome measures if that's what you used at the start. But just to check in and see where people are going in terms of their self-management goals around physical activity and exercise and weight management, and to review the exercise program and modify that as needed and progress that as someone's, strength and function, etc., has improved. It's also an opportunity to pick up where somebody may not be improving as expected, or perhaps their symptoms have worsened despite that optimal non-surgical management. And then that's a time to suggest that someone might need some further specialist assessment from an orthopedic surgeon or a rheumatologist or a sport and exercise physician, as the case may be.
And then surgery, the final one. What does that look like, and what are the recommendations?
Yeah. So the surgery one is really around, in the first instance, assessing whether someone has had an ideal time period of optimal non-surgical management. So have they really had that 12 weeks, let's say, of optimal exercise and physical activity and weight management? And then for someone at that point who might still have severe or has progressed to having severe functional impairment and severe symptoms despite that optimal management, then that's probably the right time to suggest that that person might have review, perhaps to see whether surgery might be indicated in their circumstances. So it's not saying that someone will definitely need surgery, but referral for consideration of surgery would certainly be appropriate at that time point. The most common type of surgery that someone would be considered for at that point would probably be knee replacement surgery. And there's different types of that, but they might also be considered for joint conserving surgery, such as, osteotomy. So it's at that point where the patient would receive really comprehensive information about the types of surgical options that might be appropriate in their circumstances, the possible outcomes in their situation, and the likely recovery timeframes. Importantly, there's a really strong statement in this quality statement that arthroscopic procedures are not to be used for knee osteoarthritis. So again, this comes back to this idea of low value care and no benefit to patients, and obviously carrying the risk of harms as well, and also potential risk of disease progression. So when I mention arthroscopic procedures, we're talking about things like a debridement or a washout or a partial meniscectomy. They're certainly not warranted in the osteoarthritis, because the sorts of things that they're trying to address with the meniscus are really just part of the osteoarthritis process in people aged over 45.
Yeah, we had Jonas Thorlin on a month or two ago, and he mentioned that in regards to the belief is that it's a degenerative meniscal tear that's creating these knee, complaints, but a lot of times it's the knee osteoarthritis for these demographics that is the bigger thing to focus on and what actually matters. Is there anything, so you already mentioned opioids, PRP, stem cells, and now these arthroscopy procedures. Is there anything that's not recommended for this non-operative management? Is there any like PT interventions that aren't recommended?
So the passive sort of interventions, we've really moved towards active, self-management sort of strategies that empower people to self-manage. So the exercise and physical activity focus, we've moved away from passive electrotherapy, ultrasound, those sorts of things. Symptomatic relief in terms of cold packs, heat packs, that sort of thing can still be useful. Obviously, a prescription of gait aids can be useful for some people as well, depending on the circumstances. But those passive kind of interventions that we were all taught back in the day, we've moved away from those. There's not really a role for them in the osteoarthritis management.
And then for the surgery, if patients are, relatively for where they are and their activity levels and what they want to do, if they're able to do most of the activities and hobbies that they enjoy, and they're relatively, they're not limited in the sense that they can do it, but they just suffer from persistent knee pain. Is knee pain in and of itself a viable option for a total knee replacement or partial, or does it almost always have to come with range of motion deficits and this considerable decline in function or quality of life?
Pain is one part of it. Certainly a very common reason why many people will have joint replacement surgery, but it is usually accompanied by severe functional impairment. So there's particular activities that someone's just not able to do, having difficulty getting in and out of a chair, in and out of bed, walking any distance. So someone who has severe pain and severe functional impairment, those two things go together in suggesting that well, actually maybe surgery is appropriate if that person has tried all of those non-surgical management options first, and they're either no longer responsive to that or it's not improving their symptoms. There's a conversation to be had with the surgeon about what is the likely outcome of the surgery in the patient's own situation. So, and about setting realistic expectations of what the outcome might be. So not everybody has, not everybody's pain will disappear completely after knee replacement surgery. There are up to probably about 20%, 25% of people who will have some level of persistent pain and stiffness after the knee replacement. So it's certainly not a magic bullet, and there's obviously a rehabilitation process that needs to go after the surgery itself. So the surgery is not the be-all and end-all. There is certainly a proportion of patients who will go on to need surgery and will do well after surgery, but it doesn't always result in people's pain being completely resolved. So I think that's an important conversation to have with an orthopaedic surgeon in the patient's own context. What kind of sort of pain improvement am I likely to experience afterwards, and what other what are the other outcomes I might be likely to experience? And then they're in a better place to decide, with their healthcare team, whether surgery is right for them at that point.
I know this wasn't in the clinical care standard, but if it comes to the point where there's an agreement and acceptance that a knee replacement makes the most sense and a patient is wanting to pursue this, there's still things that they may not be aware of, and you touched on it a little bit, but what are some things that physios or surgeons can discuss with the patient to set them up for the most realistic post-operative care? And I'm alluding to a lot of times patients don't realize it's going to be a relatively painful start in rehab, and getting knee range of motion is not the easiest thing, and this is probably a longer process than they were expecting. And can you touch on some of those things maybe that help patients have a more realistic understanding of the rehab process after the surgery?
Yeah, sure. I will just start by saying that this is not something that's included in the clinical care standard. It's very clearly stated that it doesn't involve rehabilitation after joint replacement surgery. But from my own experience as a physiotherapist in this area for many years, I think it's really important to be having these conversations before someone has surgery. So, before they've made the decision, but also after they've made the decision to have surgery. So they're really best prepared. So ideally, there'll be a process of getting the patient as strong and healthy before surgery as possible. And if you've already been working with the patient through their exercise program, physical activity program, that is essentially similar to the exercises that they will be doing as part of their rehabilitation post-operatively anyway. It's really important to have those conversations about what those early days will be like after surgery. So it's extremely common to have a very swollen, tight, bruised knee, and even tracking down to the lower leg and ankle, that bruising in the early days and weeks after surgery. The physiotherapist is going to be getting you up and out of bed and walking and starting your exercises pretty soon after surgery, in some cases within hours, but most certainly by the next day. And you'll be up using a frame or crutches as appropriate to you. But then there's really a process of rehabilitation that you are going to need to be working with your physiotherapist in terms of regaining your range of movement, improving your muscle strength, and in the early days really getting that quads contraction happening and regaining your function. So being able to walk with your gait aids, whether that's a frame or crutches, being able to go up and down some steps if that's what you need to do to be able to get back home again. But it's a process that really takes around 3 to 6 months. So for the first 3 to 6 months, it's very common for there to be pain around the knee and swelling and tightness, and that will continue to improve over 3 to 6 months. And then by 12 months is really, the optimal sort of outcome in terms of pain and function. And many patients are doing very well by the 3 to 6 month mark, but it's very common to have that swelling and tightness and some persistent pain then. So it is a major invasive surgery. It's a very successful procedure, but it's not something to be undertaken lightly. And the more information you have beforehand about what's involved and what you can likely expect afterwards, I think the better able, you'll be better able to cope with the recovery procedure.
Going back to the running piece, if a patient's an avid runner, and part of the reason why they want to get a knee replacement is because they believe it'll get them back to running, what are those conversations around impact-based activities in regards to, is this appropriate to return back to once I have a knee replacement? Is there evidence to suggest one way or another if it's expediting the timeline for a revision? Do you have any thoughts there?
So it will come. There will be some considerations depending on the exact type of procedure that they've had and the type of procedure prosthesis that's been used, etc. And these are conversations definitely to be having with the orthopedic surgeon as part of the decision-making process around having knee replacement surgery in terms of talking about the goals, what you want to get back to, etc. You know, there are patients who want to get back to running, there are patients who want to get back to skiing, and that may or may not be appropriate. So there's a couple of things to think about. That yes, the prosthesis is not a natural joint; it's an implant. It will not have the same structure and characteristics, I guess, as the natural knee joint. So there is potential in that situation to be wearing out a prosthesis and the bearing surfaces more quickly. And, you know, younger patients do have higher rates of revision surgery because probably they are more active and the activity requirements are higher on their knee. And there's also other things to think about, such as, you know, preventing a fall when you have a knee replacement, for example, because having a fall can, you know, obviously put you at risk of having a periprosthetic fracture, which is a fracture in the bone around the joint replacement, and that can lead to needing revision surgery as well. So it's not to say that people can't run, but it's a conversation to have with your orthopedic surgeon, because it will be dependent on the type of implant that you've had and the approach that they've used to the surgery. And so that individual context does need to be taken into account when making those kind of activity recommendations.
Is there anything else within this clinical care standard that we haven't touched on, or anything that you wanted to discuss before we close things out?
Yeah, probably just a couple of extra things. I think we talked about the communication tips that have accompanied the clinical care standard, but another really important feature in the clinical care standard this time around is the cultural safety kind of aspects, which have been designed specifically for our Indigenous Australians, so Aboriginal and Torres Strait Islanders people, you know, in the recognition that they experience a higher burden of knee osteoarthritis and have lower access to healthcare. So woven through each of those statements and through the whole care standard, tips on how to promote culturally safe care, and certainly some links to particular resources for people working with our Indigenous Australians. The other thing probably just to touch on is the indicator set that's also published as part of the clinical care standards. So there's a set of indicators that we have included in there around some of those quality statements, and they're really sort of practical things that health services can use to monitor, I guess, how well they're implementing some of those care elements that are recommended in the standards. So, for example, things like the proportion of patients who are diagnosed with knee osteoarthritis without the use of imaging, or the proportion of patients who have that individualized self-management plan with a documented advice on physical activity and exercise. So things that can be really easily kind of recorded from clinical notes or pulled out of medical records to track how well people are doing there.
Well, I think we covered quite a bit, and I will link the clinical care standard itself, because I think it's a very it's a great read, and it's not this overly jargony type of read, and I think all clinicians will get a ton of value out of it. And then we'll link some of those resources for patients as well. Any other thoughts before we close it out, Ilana?
No, just to say that, you know, on each page of the care standard, it's as you've said, it's written out very clearly. There's a section that's information for patients, another section that's information for clinicians, another one for healthcare services. So no matter what your background or which group you belong to, there's certainly very clear information there for everybody to have a look at.
Thank you so much. We will call it there.
My pleasure. Thanks, Chris.